Hi, everyone, and welcome to our fourth Digital Layla Lavan Ethics and Morality Salon series. Thank you for tuning in. My name is Michaela V, and I'm the owner of Sidewalk Citizen and one of the curators. More than ever, I appreciate our moral obligation to note that in the spirit of respect, reciprocity, and truth, we honor and acknowledge Mukintis and the traditional Treaty 7 territory and oral practices of the Blackfoot Confederacy, Sisika, Kinai, Piikani, as well as the Nakota and Tsuut'ina nations. We acknowledge that this territory is home to the Métis Nation of Alberta, Region 3, within the historical Northwest Métis homeland. Finally, we acknowledge all nations, Indigenous and non, who live, work, play, and help us steward this land, honor, and celebrate this territory. This sacred gathering place provides us with an opportunity to engage in and demonstrate leadership on reconciliation. This series is a co-production with the Calgary Institute for the Humanities at the University of Calgary through their excellent applied ethics program, and will focus on some of the ethical issues that have emerged from the pandemic. It is also a continuation of two salon series that we have been running in the bakery in the past 4 years. We are truly fortunate to have enlisted an incredible lineup of speakers, and I would like to thank my fellow curators, Dr. Jim Ellis, Professor of English and Director of Calgary Institute for the Humanities at the University of Calgary, Dr. Justin Weinhardt, psychologist and Associate Professor in Organizational Behavior and Human Resources at the Huskian School of Business at the University of Calgary, and award-winning journalist and moderator of this series, Christina Frangu. I would also like to thank Boulevard Noir, a local band who composed the music that accompanied the opening slideshow. One of our most memorable Tzavta Salon was on Valentine's Day 2017 with Christina Frangu as the guest of honor, who had then just published her heartbreaking, earnest, and arrestingly beautiful piece about dealing with the loss of your soulmate and the impact of widowhood. A salon about love, true love. Dr. Bettin is not only an accomplished and distinguished ethics professor who wrote extensively about ethics during pandemic, but is known for her influential work about end of life. Her writing comes from an academic, compassionate, and personal experience. As our series draws to a close, we have moved from metaphorical, conceptual ideas through the broad perspective of policy and now on to the human individual aspect. I am honored to welcome our guest, Dr. Margaret Peggy Bettin, and our moderator, Tzavta alumni and friend, Christina Frangu. Christina Frangu is a writer, journalist in Calgary, Alberta, who specializes in writing about health, medicine, and social issues. Her work has appeared in The Guardian, The Globe and Mail, Maclean's, Alberta Views, and Reader's Digest. She writes about topics such as refugees, grief, loneliness, and public health. And without further ado, I would love to call Christina and Peggy to our conversation.
Thank you, my friend, for that very nice introduction. I have been looking forward to this talk for a month, really, since Peggy confirmed that she'd be available to do this with us. I first came across Peggy's name when I read a story about her and her husband, Brooke. It was just a few weeks before he died, and it was a few weeks after my husband died, after very different circumstances. Even so, there were elements of the same concerns. What is the best possible death for this person? How do I support them and help them to get there? And how do I do this? What does that mean? How do I do this when what I ultimately want is to keep my person alive and healthy, even if that's impossible? And I was struck by her openness in writing about this. And since then, I've also turned to her work many times professionally. As I researched for stories I was writing about medical assistance in dying and end-of-life care and religious refusal of medical treatment. Peggy is the Distinguished Professor of Philosophy and Adjunct Professor of Internal Medicine in the Program of Medical Ethics and Humanities at the University of Utah. She holds an MFA in fiction writing as well as a PhD in philosophy. She's written prize-winning short stories and authored, co-authored, edited, or co-edited some 20 books, among them a pioneering book looking at infectious disease and bioethics called The Patient as Victim and Vector, Ethics and Infectious Disease. It came out in 2009, and I was reading it recently and really struck by how many of the things she poses as possible have now become real life ethical quandaries. Issues we're dealing with across the globe have been part of her career works. She's been engaged in research on age rationing in medical care, end-of-life care, medical assistance in dying, and autonomy around end-of-life decisions. She has been named one of the mothers of bioethics, and it's an enormous privilege tonight to speak with the extraordinary Dr. Peggy Batten. Please join me in welcoming her onto your screens.
Christina, I certainly want to thank you for that very touching introduction. I knew that you had lost your husband, and so I understand what that's like. And I think we both understand how complex decision-making at the end of life is.
Yes.
Both for the person themselves and for the one who cares about them, right?
Very much so. That this has long-term consequences for what happens in those very important moments at the end of life. I do want to, before we go to, I do really want to get into that, but I wanted to start tonight by talking about the title of our talk tonight, and what is it that I had several people ask me, what do we mean when we talk about the triaged-against?
Well, we're all familiar with the discussions, and everywhere that COVID is, which is now everywhere, there are discussions about what to do if we don't have enough ventilators to go around. And ventilators is often used as a shorthand term for other things that are part of critical care, and may mean the difference between survival and non-survival for somebody with COVID. And that would include things like dialysis, various medications, oxygen supplementation of various sorts, and every one of those things, including also personal protective equipment for the staff and other factors. We've seen shortages in various parts of in our country and also in various parts of the world where these were all in critically short supply. So how do you choose who gets the ventilator? This isn't about people who will survive or who are highly likely to survive anyway. And it's also not about people who probably almost certainly won't make it, no matter what we give them. It's about the people for whom getting the ventilator or any of that other stuff is likely to make the difference between survival and non-survival. So here's the question. There's lots and lots of attention to how to decide who gets the ventilator. And as far as I can see, there is almost zero attention to what do we do for or owe the person who doesn't get the ventilator. Remembering that they were both, by assumption, in pretty much the same position.
Right.
They would both be more likely to survive with it, but we only had one. And no way to give it to both. Of course, there are now schemes for putting 5 people on a single vent. Let's just suppose there were 6 people who needed it. I mean, we can play these scarcity. So what do we owe the person who is triaged out? We don't think about that, or don't think about it enough.
So what should we be considering when we think about that? Is there a humane approach for what we do for people who've been triaged out?
So I've been thinking about it a little bit and trying to think about from the point of view of what I personally think I'd want if I found myself in this position, which presumably any of us could be. The likelihood is greater for for people who are older or compromised in various ways. But this virus is so tricky that we don't really know. We can't say for sure that nobody would end up in this position. So I can think of 4 things we might want, but I'd invite the audience to tap in on the Q&A if you have other ideas about what things you might actually want. And I'm just moving this over here so I can see it. Yeah, because it's nice to have a kind of a conversation.
Yeah, yeah.
For one thing, and you can tell me what you'd want, since we've both been in situations where we saw someone approaching death. And those were situations in which there wasn't anything we could do about it much. There wasn't any further treatment or technology.
Yeah.
Well, I think, thinking about it with respect to COVID, I think I'd want full information. I'd want to know as much as I could about the disease, about the likely course of the disease, and I'd want to know why I didn't get the ventilator and somebody else did.
Would you want to know what the circumstances were of the other person who you were being considered a rival to for a ventilator?
Well, I'd certainly want to know if I were, say, of some minority group and somebody else got the ventilator, whether that was a decision made based on race. Now, all the event triage policies I've seen, all of them exclude decisions made based on race. Mm-hmm. Some exclude age limitations. Others exclude, personal status and stuff like that. So one thing you'd want to know is whether the decision was made in a fair way and whether you could protest it. Now, some people might say, well, here I am, over 70 or over 80 or over 90, whatever. And I've had, a good crack at life, and I'm happy to have the vent go to somebody else with a better chance. Not everybody will feel that way, but that's one kind of thing that it seems to me you owe to the person who's the loser in a triage event is honesty, openness. That's one thing. Of course, the person might already be so sick that it's not possible to have this conversation, but let's just assume they are.
One of the things that I think that makes this so difficult is there's so many questions about this disease, about this illness. What does it mean? What is the likelihood you will survive?
Right. And there's no, as far as I know, there's no fully accurate way of predicting, of prognosticating in this situation. We have some general prognostics, but this particular virus is still new. Mm-hmm. Only been around for a couple of months, and while there are lots and lots and lots of cases, we don't have the longer term experience to actually trust what it's going to do. This other person. So that was one thing that you'd want. Yeah. I think you'd want the right to personal choice. We actually just mentioned that. Do I really want to try to get this vent for myself, or would I rather give it to someone else? So that allows me to make that choice in a sense, rather than having it be made by somebody else. And there are many other things you'd want as matters of personal choice too. One quite controversial issue is whether you should have the right to, this is about personal choice, try unproven therapies. Now, of course, unproven therapy of current fad, taken by various world leaders, not just one, is hydroxychloroquine, I'll try to say this carefully, not proven to be of any value in COVID, and also to pose certain kinds of risks, arrhythmias. Just the same, someone might say, well, I really believe in this stuff, and I'm not taking it away from anybody else, and although I don't have malaria, right, I just want to try it. Give it to me, doc. Should you be entitled to do that? I think it's France, just passed a law prohibiting the use of hydroxychloroquine, right?
Oh, I didn't know that.
I think I just read that today. I think that's too strong. It seems to me that where the person who is, remember we're talking about somebody who's been the loser in the triage game, and so much more likely to die, can we not allow them to try whatever they want, right?
So,
right.
And so the rules would be different. You think are the options different for the person who's sort of been triaged out as compared to someone earlier on in their disease course?
Very interesting way of putting it, right? Should they be different? Since it's, after all, our policy that has put them in this position, right? We're the ones who devised the triage policy that allows for, sometimes it's a randomization of, essentially coin flipping. Sometimes there's a gradient scale of, eligibility access. But whatever it is, this is a person who's been disadvantaged in this competition. Mm-hmm. Should the rules be different? I think in certain ways. Now, trying an unproven drug, the worst it can do is kill you, right?
Yeah.
But of course, that's what's likely to happen anyway.
But maybe not. Maybe that's not the worst. Maybe the worst, though, is that there's someone else who needs that for a different illness that they regulate.
That, of course, would be a different case. If there were a shortage of this hydroxychloroquine, which there isn't now, there was some discussion of it. Or azithromycin is sometimes used, and that's the Z-Pak that's used for pneumonias everywhere. There's plenty of that, or any of the other strange things. I don't know. And it might be a case-by-case basis. It's okay to try this one, it's not so okay to try that one, or it's okay to try this one unless there's a shortage and somebody else can't, who really could profit from it because they have lupus or something else that is ordinarily used to treat.
Right.
Yeah. Those are all quite nuanced questions, but I think it's important to think about how we should treat somebody who is in this position.
I don't know if I've seen this conversation. I don't know if has anyone had. I have not seen any hospital or jurisdiction talk about what happened there.
The whole point is we pay so much attention to who gets the treatment, the vent, and none, or almost none, to the person who doesn't. So most, so I think there are two more things you'd want. One is rights to communication. And this one, although I've been reviewing some of the triage policies, they often mention palliative care, right? But something they don't mention, at least I haven't seen one that does, is the right to communication. So there've been many, many stories about people dying in hospitals with no contact with family, loved ones, no in-person contact. Visitors aren't allowed into the hospital, but no arrangements either for even video contact. Here we are, we're having a conversation. We can see each other. We can talk to each other. I think there are people who can see this happening, but that hasn't been made possible for, at least in many cases, for patients who are now facing death because they didn't get the vent. A nurse once remarked to me, this is an ER nurse, she said, this wouldn't be so difficult. Everybody who comes into the ER has a cell phone, but none of them have chargers.
Yeah.
So it would cost a hospital $100 to buy a whole set of different kinds of chargers for different phones. You now see accounts from time to time of a compassionate nurse or staff person using their cell phone for a patient to contact, but that's not good enough. It seems to me that promoting, facilitating communication ought to be considered essential treatment for the person who's facing death, not just a convenience, but something really important. That's essential for the person, And it's also essential for the about to be grieving family.
Yeah. I think until you are in that situation, you don't realize all the small things that go into having a really compassionate, caring experience, and what a world of difference free Wi-Fi and really good Wi-Fi would make for every patient in the world.
Right. One last thing, and then we'll go on to other questions.
Yeah.
I think the fourth thing you want is the right to a humane death. So here the point is to make sure that somebody isn't just, as they say, kicked to the proverbial curb, that care is still provided to somebody even as they're dying. That would mean perhaps palliative care, hospice style care, pain management, not being simply sent home with nothing, right? No discharge without supportive or palliative care. Often people are sent to a sort of converted nursing home that now is all for COVID patients. We want to know what the conditions there are like and what kinds of care people are getting as they face death. Okay, so that's thinking about an area for all the talk we've done about COVID. This is something that I don't see discussed anywhere.
Yeah.
Yeah. It may never come to that. We may never need to triage. It hasn't happened, I believe, here. And I'm told that it hasn't happened even in New York, our worst hit city. But it did happen in Italy, right?
Yeah.
Triage. And it could happen anywhere, either with this outbreak or whatever the next one is.
I wonder if people listening to this who are home with people who have cancer or other conditions feel a bit triaged out of the system because we are prioritizing everyone with COVID or the potential for COVID. Nice point.
Nice point. Maybe they'll let us know on the chat line here.
Yeah. Well, I saw, is there any country where the decision, where a triage decision had gender in it? That's one of the things that's popped up here.
Well, I don't know, and I can't tell, I can't say reliably where this has actually been practiced. And I can't say reliably what's true of all the triage policies that are being ginned up everywhere. Some are being dragged out from past preparations and some are being newly constructed. I suppose the issue is, would gender be a disqualification for access to the vent? We do know that the death rate has been higher for males. Right? Would being male be a reason to not get access to the vent on the grounds that the female competitor was more likely to survive? I don't know. It's certainly something to think about. Right.
And in Canada, one of the oddities here is we have more women who have died than men.
Really?
Yeah, yeah, and but that also reflects like we have a very high fatality rate from most. I think something like 1/3 of the deaths from COVID in Canada have been in long-term care homes.
Oh, right. Well, I think it's not quite that high here, but it is long-term care homes also.
I see a question here. Should the personal choice also be given to those of the triaged 4 who may be willing to forego the ventilator even though they were chosen?
I think absolutely. If it's genuine personal choice and not being pressured into something, right?
Yeah.
There are saints around, people who are deeply altruistic. And I think honoring that choice is absolutely the right thing to do. Making sure that it's not pressured, or that it really is needed by some other party, or right. And now there's a little distinction between giving the vent or treatment to another party who actively needs it right now, and not giving to the person because we might need it later on for somebody, right? When you actually don't know whether there'll be sufficient scarcity so that it will actually be used. Those seem to me to be a little different.
I see one question here. How would you contrast the ventilator triage decision with an organ transplant triage decision?
Oh, what a hard question. That I don't know how to answer that other than to say organ transplant scarcity is continuing and chronic. And it's depending on the donation background policies of a country. It is either greater or lesser depending on, for instance, whether it is, the default is that donation occurs unless there is an objection by the family or by prior, designation of the patient. Or a country like this one, where organ donation is opt-in, right? So when someone has, say, a severe accident and survive, then there's a team that approaches the family and asks if they'd be willing to donate. That's way different from it being assumed that donation can occur unless the family objects, right? And in one case, the supply of organs is much greater. Will this be a perennial problem? Maybe we'll develop, scaffold-grown lab organs or other ways of doing things. But for the moment, that's a perennial problem. This is a crisis problem.
I want to, if we could go back a little bit to your personal experience, and rather than the pandemic, because I think, you were just we were talking about how hard it is to make that decisions in the moment of. And when I first read your story, I was really struck by, you can spend a long time researching these things and it's still doesn't make it simple. Like, you still don't know. And your husband Brooke had his a bike accident in 2008. And maybe could I ask you to tell people what happened and how did that challenge your beliefs about autonomy and decision making about end of life care?
Well, I had for many years, that is my entire academic life, been a supporter of medical aid in dying, and convinced that it could proceed without abuse. We did some research that made that pretty clear, and that it was a way to respect the wishes of people, and that we should honor those. So then my husband, who was riding downhill on his bicycle in a quite heavily traveled canyon road, no cars, but lots of, other bikers, pedestrians, collided around a blind curve with another biker who was going uphill. And the other guy wasn't hurt. He was just tossed off his bike, and but Brooke broke his neck at a very high level. So it just so happened, because this canyon is right in the middle of this city and there are lots of people, there was a fully trained flight nurse out jogging who came upon this within a minute or two afterwards and saved him, right? So, but this, he broke his neck at such a high level that he was completely paralyzed from the neck down, from the tops of the shoulders, and required a ventilator. He was happy. He was so grateful that he'd been rescued. I normally went biking with him, and if I'd been there, I would have been the decision maker. Would I have said to this flight nurse, who, after all, was not on duty at the time, nobody would have known that she had these skills. I could have said, just keep on jogging, and he would have died on the spot. I don't know, knowing enough about total quadriplegia and so on, whether I would have said that or not. I don't know. Anyway, he was enormously grateful to have been rescued, lived for 5 years after that. A very difficult but also deeply rewarding life. And then he said, I've done what I can. I need to have my ventilator disconnected, right? Which is legal.
Hmm.
This was not an easy choice, and it was made over quite a long period of time and reviewed heavily. But you have to honor a choice when you're sure it's a genuine choice and it's somebody you love, right? COVID deaths, I think, may be different because they're under much greater time constraints. My husband's choice was made over a period of 5 years that he lived after this accident.
Yeah.
What about your situation? As long as we're talking personally, and
Yeah, it's
the
okay.
world is watching us out there.
Well, and I was gonna, is it hard for you to talk about?
No,
Yeah,
no. I
I
think his view was, if my story can help other people, I will be willing to tell it. He was quite clear about that. We kept a long blog that was out there. There were various articles all over the place and so on.
So,
Anyway.
ours was very fast. My husband was 36, really amazing athlete, loved cycling. And in fact, there were, when he was dying, you know, he sort of marveled that he hadn't died skiing or cycling. And he was in the last week of his orthopedic surgery residency, and he hadn't been doing, he hadn't looked well for a while. But he was gearing up for his big board exam, and so everybody we knew was sick and not looking great. And then he had his last day of residency, of clinical duties, and they had a graduation dinner that evening. And he called me from the dinner and said, "I don't feel well. Could you come get me?" And you know, I just knew then that my life was changing. You have that moment and you know. And we went to the hospital, and he was diagnosed with a very aggressive stage 4 kidney cancer, and he passed away 6 weeks later. Yeah. And so it was, we didn't have a lot of time to wrap our heads around what was happening. But and we spent almost the entirety of it in the hospital. Like he was never quite stable enough to come home. So very quickly we were in this place where it was obvious what was happening. Like he was sort of disappearing by the day. And at some point I understood, as much as I didn't want to, what was happening, and how do you make decisions here that reduce the amount of suffering. And he said to me a few days before he died, I wish we had, at the time it was called physician-assisted suicide still in Canada. And he said that to me in the presence of 2 family members who are doctors. And he said, for the first time, I really understand it. And so I've written stories about that ever since. You change in those times. And one of the things that I wanted to ask you about is, what will be the consequences for people to not, for the bereaved, for the people who lose their loved ones? What will be the long-term consequences of not being able to be there for those moments?
Oh, you mean we're talking now about COVID? I think it's, well, I don't think we know yet, because those deaths have only happened in the past couple of months. So if we're talking about long-term consequences, will the grieving process be more difficult? Will it be, flavored with a kind of guilt that says I somehow couldn't get to them? I tried to break in the front of the hospital or whatever. They wouldn't let me in. There was something so unfair. Does that compound the sense of loss? Or I don't think we know. Maybe there's somebody out there writing in who has more experience with this, but it's I think a serious problem. But it's something we don't have to let happen. That is, if we consider that kind of communication as deeply important, both for the person who is facing death and for the family members, then we have to think in advance about how to make that possible, how to facilitate that. And I think that's as important as much of the other stuff we do with respect to COVID. Right? Recognize that it ends in death, but don't interfere with as much of the leave taking and farewell saying, and as well as last rites and other things that are really important to people at the end. How can we just bar all of that?
Is sort of FaceTime and a phone communication enough, or would you like to see sort of a standard PPE for all family members?
Well, that's a standard PPE for all family members. I'm aware of one story of a person who happened to have her own PPE and wasn't allowed to put it on in the hospital and observe all precautions to see her dying. It's so stupid. Yeah, yeah, it's anyway. What we're doing now, you're a couple thousand miles away, I guess. We're having a conversation. I can see your face, right? You can see mine.
I'll answer some of these questions that have popped up here on my screen. So I'm going to take this one here. As a resident physician about to embark on a 4-week ICU rotation starting on Monday, these are discussions we have all the time, mostly with non-COVID patients. But oftentimes when we are considering the need for life support measures such as intubations, people can be too sick to be able to make that choice for themselves. So we rely on family to make decisions. And now we do this all by phone. Oftentimes the response from families is that I don't know what to do, I need more time. In these situations, we don't have time, and it often falls on physicians to make these decisions, and we have to decide if we think there is a benefit or not. If we do not think there is any benefit, like a chance of survival after interventions, we don't have to offer it. This was true before COVID as well. Is there a way we should be communicating with families to try to ensure that they are in fact able to make an informed decision in a rather quick time frame?
Oh, what a hard question. And what a hard situation for the writer and all of that person's colleagues all over the medical world to be in. The pressures of time. I don't think there's an easy answer to this. Is there a way to make it easier? Certainly, assuming that the family members know that the person's hospitalized with COVID, that there are already a lot of, flags, red flags waving there.
Yeah.
And the news that things might not go well, or that further care is not indicated, further curative care is not indicated. That can't be news either. Although maybe it is. I don't know. I'd be interested if the author will write into the chat line again to see if they have an answer, right? Because well, I assume that every clinician who is faced with this situation understands how difficult it is and how hard it is to give a global answer. Mm-hmm. I don't think you can say, oh, do this or don't do that. You can say, just do what they're already doing, which is talking to each other every day about these situations. So
this has really, I think that when you learn this very quickly when you're sort of thrust into the medical system, that family is an essential part of how this system works and how this. Okay, I'm going to ask, this is a question from Heather, and they're popping up on a separate screen here for me. I was diagnosed with non-Hodgkin's lymphoma in January and started targeted therapy in April. I wonder if I would be tempted to hide my asthma if I were to get COVID-19, and faced with the knowledge that there was a triage situation undertaken, there is enough working against me with the cancer.
That's a very, very interesting question. And I think it depends on hospital policies, what kinds of protocols they've developed. Some of the ones I've seen have established a triage committee, which is independent of the treating physicians The decision about access to the vent is made by another party that has facts about the patient's condition, but some of them say no other personal demographic facts, like sometimes age or race or social standing of any sort, social status, minority status, stuff like that. So I don't know, hiding asthma, well, if you can do it, great, right? But there are people who will be involved with your respiratory situation, whether they can detect it or not. The background cancer stuff, well, will they know that? Will they have access to your records? Presumably in these days of electronic medical records. You can't run and you can't hide. That is, they presumably know this. Will they factor it into a decision or not? Sounds like this is a person of tremendous will to keep going. And so I hope that gets factored in too. Thanks for writing in, whoever it was.
There are some good ones.
And we hope you're never in that situation.
Yeah.
Yes.
There's some good ones here. Oh, we have I think this is a response to the question about from the healthcare provider. Not having families in hospital definitely adds to moral distress of physicians and nurses. Being the one holding the phone up for a loved one in tears, as you as a physician can't really console us hard. And I imagine it is incredibly painful for families if it is for us as clinicians.
Yep.
There's a question. There's so many. Okay, and I have them from before. I'll read the one right under. Oh, sorry. Go ahead.
That provides another argument for taking rights to communication to be an essential part of care, even in the wake of being triaged out, because it's so hard on the clinicians to holding up a phone, right? We can do better than that. Right? We can do much better than that with a little advanced preparation. And
I was talking with friends who are physicians, and we were asking about each other about moments in the pandemic that they had cried, and someone said that was their moment, holding the phone up for as they were palliating someone. There's a question here. In a socialized medical system like Canada, how do we determine a valid allocation of our resources for a collective good?
Well, let's see. I think I'll just sidestep that one and say, I don't live in that kind of system, and so the problem's even harder down here. I think that you can, that's, well, some of the principles often cited are try to save the most lives, or try to save the most most expected life. That means preferring younger people over older ones. In the other case, it might be preferring over older people. Some policies are, or at least some argue in favor of saving older people rather than quite young ones, because the older people have more wisdom and so on to contribute. There's, the philosophic discussions of these prioritization principles all over there. I think it's not the case that there's an easy right answer. Talk to this philosopher, you'll get that answer. Talk to that one. The only responsible kind of answer is, I think, it is impossible to construct a global answer. Let's keep thinking about what in this particular situation seems to make the greatest sense, but that's still not an answer. Then the answer is, I don't know.
I feel like that is, I feel like in all the conversations we've had through this, I keep coming back to, I don't know.
Yeah. And furthermore, I don't really trust anybody who says they do know, right?
So I want to ask some of the questions that were emailed to me this week.
Okay.
as a society, we have prioritized the value of safety, but at a trade-off of other values. What other values are being traded, and what do you think the consequences will be at the personal level and society?
Well, that's such a broad and general and interesting question, but we could just point out we were just talking about that. So safety was the primary announced value in not allowing family members to come into the hospital to take leave of someone who is expected to die. So what's the safety? Well, they might bring more COVID into the hospital, or they might take COVID out of the hospital and take it somewhere else. It's two roots of safety concern. But of course, to say that that's the primary concern, should be the primary concern, overlooks the value of these last human moments that seem to me impossible to weigh or difficult to weigh against the value of safety, when the likelihood of cross-contamination, cross-contracting of COVID is not huge if, precautions are taken, right? And to say, well, we can't let anybody in here, that seems to me to be overdoing it, right? That is taking long shot risks of threats to safety over clearly important, present, and utterly valuable human communication right at the moment. Anyway, so that's the answer to that question.
And do you think if we have, for whatever future waves we have, do you think that we will make those trade-offs a little differently?
Well, if the general question here is, will we learn anything from this epidemic, from this pandemic? That's a little harder to answer.
Yeah.
I think we'll certainly learn some scientific and medical stuff. And we, I think, have already learned how to act faster in trying to construct vaccines, and developing rapid testing techniques. We don't always use them where we might. I've been very interested in whether we could try to control transcontinental transmission of infectious disease. Here's a perfect example. So SARS, as I'm sure Canadians remember, came to Canada, came to Toronto via a grandmother who got on the plane in Asia somewhere, brought it to, not on purpose, of course, she didn't know, brought it to Toronto, and 44 people died, right? Now, we didn't have this technology then. All we had was temperature scanning to try to control SARS. But we now could do rapid testing for current disease, or also antibody testing for previous COVID. And we could do that at airports. So Emirates airline, just on the 15th of April, did do rapid testing for a flight from its home base to Tunisia, where it did testing in the airport, the waiting gate for a international flight like that. It tested everybody. The health authority was there, and that seems to me to make perfect sense if there is a risk of transmission like the one that's there now. So if we just caught this grandmother and said, we're sorry, we just can't let you get on this plane, that disease, and if it happened everywhere, would not have come to Toronto or anywhere else that SARS was transmitted. You have to think long-term like that.
It's interesting that you bring that up, though, because that's a thought experiment you wrote about in 2009.
Right.
But what struck me about it is you said, I think you said it might be, some might think this is outrageous.
Uh-huh.
And when I read that, I thought, well, no, I don't know if it would still be considered outrageous.
Well, isn't that the amazing thing, that the technology, so that was a decade ago that book appeared. which, by the way, we are about to, I think, bring out a reissue of. And here it is, just so you can see it. Look at that.
Okay.
Patient as victim and vector.
Very friendly.
Well, that's what the patient is, victim and vector at the same time. That's what makes it so hard. We now have the technology to do that kind of rapid testing. We could do it at every airport. We could do it, you already get your luggage screened and you get your person screened. How difficult would it be to do screening for a transmissible infectious disease?
Do you think people would tolerate that possible perceived violation of their liberty to have to go through that before they get on a plane?
Well, they have to have their body scanned already, and their luggage scanned. And there was a lot of whining about it at the beginning, but of course nobody complained. They complain about the length of the lines, but they don't complain about the principle, right? And it seems to me that once you think through the notion that scanning you is part of scanning for infectious disease is part of the way, it's like scanning for weapons or scanning for bombs and all the other stuff. That also protects you from stuff that other people might carry on the plane. It seems like an imposition on you, but it's actually a protection for you and all the wherever you might be going. Especially if you can use sampling techniques that are less inconvenient than the nasal swab. That's said to be not very comfortable, brief but not comfortable. Or a finger stick you can use for antibody testing. But there are now also, I understand, saliva tests that are pretty good. So producing a sample of saliva is not difficult to do. And if that's effective, I can't see any good reason for objecting to that, except for the fact that you'd want to know whether your own DNA was tested and collected and used in some way, or others had access to it. As I understand it, the rapid tests that are used do not test the person's DNA. They look for fragments of the DNA of the virus. They're only looking for the virus or pieces of the virus. And so that quite sensitive personal information, your whole genetic thing, isn't part of the results. You'd have to destroy the samples and put in safety precautions, but it's way less invasive of personal information than you might think. So anyway, that's a little fantasy, right, from 10 years until the present. And
it's amazing how it's changed. I'm gonna get to some of these other questions that have popped up here before we run out of time. Peggy, do you have a view on the use of metrics constructed on the prospect of quality-adjusted life years to determine the availability of various medical therapies to Medicaid patients in the U.S.?
This is such a complicated question that I'll say, no, I have no view for it. My view would be that this is an extremely complex question, and the fact that somebody is actually asking it is a good sign, right? That the use of this way of doing things should be always open to challenge. But what answer I might arrive at or somebody else might arrive at, I don't know. And you have to ask, what are the alternatives for assessing, quote, quality of life at all? Number one way is to ask the person, right? Right, start there.
I have another one here. It seems that telling the stories of those triaged against is the best way to raise it as a real issue. And yet there is often little time to capture the story accurately. How best can we tell these stories?
Oh. Well, I don't know the answer to that one either, although I think a skilled reporter or personal narrative folk anthropologist, for instance, some people are trained to do personal stories. So remember, this will be starting with somebody presumably in the hospital whose condition deteriorates enough so that the next move would be ventilation, mechanical ventilation. So if you had someone there, this gets to be, it seems a little invasive, but if that person wants to tell their story, right? There's somebody right there. Or you can start before one's condition deteriorates. And of course, if you're telling stories, you want to tell both sides of this, or you want to tell everybody's story if you can. What happens to the person who does get the vent? Are they racked with guilt for because somebody else didn't get the vent that they got? That's also a question. So I can imagine a social anthropologist, or even a good storyteller reporter, thinking through some of this. And I imagine the stories are different in every case. It's just that I think the main point here is we shouldn't just look away. We shouldn't throw someone to the curb. We should be as attentive to those people, recognizing that this is a crisis situation. And we couldn't do what we thought was the best thing for everybody, but not to ignore the people who lose out. That's all. So telling those stories is a good idea.
I had a question that someone emailed me today that I really wanted to ask. I almost emailed you to this one today because I wondered if you'd want to have time to think about it. But then I think your knowledge is so in depth that you'll be able to answer it without a heads up. So here was the email that came. As one of the people most well read on the end of life, what are some passages from history or literature that can make us better understand what is happening to us? Related, are there any passages that give you comfort during this time or when you have dealt with the death of loved ones?
Oh my gosh. It would take a long time to itemize all of those. I can tell you one passage, though, I am very interested in. It's a slightly bit different topic, but it's about end-of-life choices. And this is from a writer, somebody was attached to the, I think I'll get all the details mixed up if I try to remember them on the spot, but who is attached to the Roman consul who is in charge of, areas in the Eastern Mediterranean. And they arrive at the island of, I believe, Kos. And there is a woman who is said to be 90. She says to the Roman consul, "Sir, I am in the best of health. I have had good fortune all my life." She's obviously a woman of property. "I have 2 loving daughters who will carry on my name and so on. And I wish to have you attend my death, which will be provided by with the hemlock." I wish I could quote it. It's easy. I can post this passage too if you want. And he tries to talk her out of this. She wants aid in dying in perfect health. She says, "I want to go. Fortune has always smiled on me, always shown me her smiling face. I want to leave this life before I see her frown." So this is what we call completed life, or anticipatory or preventive aid in dying. And so the Roman consul tries to talk her out of this, makes no headway. He finally consents. She drinks the hemlock. And the really wonderful story, part of the story, is that the Roman consul and all his, attendants and so on, leave bathed in tears. So, but it's about a human situation, about whether, if we're thinking about an end of life, not the tragic accident or tragic illness kinds of stories we're talking about. But for someone at the far end of a life that will eventually come to a close, making a conscious and apparently autonomous decision to leave. I think that's one of the next issues, if we're talking about end of life stuff, that we need to think about hard, right? I think it's part of the discussion there in Canada, as it has been in the UK and the Netherlands. Not yet in the US, but we're a little further behind on some of those things. Anyway.
Well, I normally ask a different question to end, but I think that is the best way to end this discussion. And we're also a little bit over in time. So I think Mikal will come back on the screen. That's the plan. And Peggy, thank you so much for this. I've really enjoyed it.
It's very, I hadn't known about the Sidewalk Bakery, but it is, strikes me as totally wonderful. So whenever we're able to travel around, I'll turn up. How's that?
Your rapid screening done at the airport and come visit us.
That's right. Thanks so much. All right.
I wanted to thank you again for joining the Salon. Thank you, Peggy. Thank you, Christina. Thank you for the thoughtful conversation. I particularly want to thank Sean Lindsay, the coordinator for the Institute of the Humanities, for doing all the technical behind the scenes work and making this happen. The Calgary Institute for the Humanities for being a keen sponsor, and particularly Dr. Jim Ellis and Dr. Justin Weinhardt. Our last and final conversation will take place next Wednesday, June 3rd at 7 p.m. and we'll be hosting Dr. Yuval Neria, Professor of Medical Psychology, Director of PTSD Treatment and Research Program at the Department of Psychiatry in New York State Psychiatric Institute at Columbia University Medical Center. If you wish to register, please join our email list or the Institute email list. And again, thank you for the gift of your time and your attention. We hope to see you next time. And until then, good night. Thank you so much.
Thank you.
Thank you.